Good morning, everyone. This is Keshav. I'm one of the second year residents at Memorial Healthcare System in South Florida. I'm presenting a case of an unoperated left ventricular pseudoaneurysm, which developed after an inferior lateral STEMI. It wasn't operated on, and the patient was able to survive with this massive fifth chamber for at least 6 months post discovery. Just a quick background: LV pseudoaneurysms are narrow-necked outpoachings, but the difference between a true aneurysm and a pseudoaneurysm is that pseudoaneurysms are contained within the pericardium. This in turn makes the chances for rupture in case of pseudoaneurysms much higher. Usually surgery is considered early on, and conservative management is usually not recommended, especially given the size. Our patient was a 76-year-old male, had all the risk factors for atherogenic disease, including active smoking status, hypertension, hyperlipidemia, and peripheral arterial disease. He came in with subacute onset of chest pain that he described was there for the past 2 weeks at least. Initial EKG revealed ST elevations in the inferior and lateral leads. He was taken to the cardiac catheterization lab immediately, and the culprit lesion was suspected to be 100% occluded mid-obtuse marginal artery, which was stented. The cardiologist also mentioned that even after placement of the stent, the vessel remained diffusely small, likely a combination of spasm and thrombosis, and they said that they were also suspecting that this was subacute, as the patient was having several days of chest pain. As you can see in these cath images, even after the flow has been restored in the obtuse marginal, it's very minimal and it's not exactly what you would call TIMI grade 3. Patient was discharged on some components of the GDMT and DAPT. At that time, the first echocardiogram showed an EF of 48% with LV lateral wall hypokinesis. 3 months later, he was admitted to the hospital with signs concerning for a CHF exacerbation. Repeat echo this time revealed a reduced EF of 40%, but was extremely concerning for a large pseudoaneurysm adjacent to the lateral wall of the LV. It also had to and fro blood flow, but thankfully there was no intramural thrombus yet. Patient was offered surgical repair, but due to personal reasons, he decided not to go forward with it. He was managed conservatively with IV diuretics just for the CHF and was discharged. He remained relatively symptom-free for the next 6 months. He did receive an outpatient thoracentesis for a pleural effusion. The fluid analysis revealed transudated fluid, likely secondary to the underlying heart failure. 6 months after the second hospitalization, when the LV pseudoaneurysm was initially found, he came back to the ED with signs of worsening dyspnea and x-rays showing bilateral moderate to large pleural effusions. At that time, the EF was improved at 55%. However, there was severe diastolic dysfunction, grade 3 at this time, and the pseudoaneurysm had extended pretty much throughout the lateral border of the LV. Given the overall poor prognosis, the patient decided to transition to hospice for comfort care, where he passed away within 5 days of hospitalization. This